Hey, welcome back. My name is Nick Kuntz. I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine. And I'm back with, I think this is number 4 in a series of full-length lectures that I'm recording, really for the purpose of any resident, any fellow out there that gets stuck at home either in quarantine or gets furloughed from work as we're sort of dealing with the escalation of the COVID crisis here in the U.S. Just wanted to do what I can do to put out some resources. These lectures are certainly not going to be comprehensive of everything you need to know, but just some stuff that I had readily available that I wanted to share with any residents and fellows out there. Hope you enjoy it. Stay safe, stay healthy, take care of each other. But this talk is going to focus on salivary gland neoplasms, and this is, to me, it's a topic that causes some confusion for head and neck radiologists, for neuroimagers. And I think that the way I try to approach these is in a very practical and pragmatic manner. And I'm going to share with you some of the strategies that I use to approach these cases. So hope you enjoy, and we're going to talk about salivary gland neoplasms. So first of all, I still have no disclosures. I haven't found any over the last few days. But I have lots of people I'd like to thank who contributed case materials or graphics that I've used in this presentation. So first and foremost, I'd like to thank Rick Wiggins, my friend, my mentor, the person who really is responsible for teaching me everything that I know about head and neck imaging, and the reason I'm able to share a lot of this with you. I'd also like to thank Chris Mosier, my colleague here at Indiana University School of Medicine. Chris has been another great teacher in my life, and I've learned so much from her as far as head and neck imaging goes. I'd like to thank Whitney Finke, one of my former residents, who years and years ago we put together a presentation for, I don't even remember what conference it was, on parotid gland tumors. So we're using some of these cases, so thank you, Whitney. I'd also like to thank Troy Hutchins out at the University of Utah, a good friend and former attending of mine who shared some cases with me for this. And Sean Dotson, also one of my former residents and fellows, who was kind enough to share some case material. So lots of people really shoulder a lot of the responsibility for me being able to put this talk together. So Rick, Chris, Whit, Troy, Sean, thank you so much. I'm going to share some of those cases that you've shared with me. Okay, so let's get started. So in the head and neck, there are 3 major salivary glands. Really, there's 3 pairs of major salivary glands. You have your parotid, your submandibular, and your sublingual glands. In addition to those, you have numerous minor salivary glands. And when I say numerous, I mean on the orders of hundreds, maybe even over 1,000. Now, each of the major salivary glands are located in their own unique space or spaces. So the parotid gland is found within, as the name might imply, the parotid space. The submandibular gland, interestingly enough, is contained within the submandibular and sublingual spaces. It's predominantly within the submandibular space, but there's this small appendage that sort of protrudes off the upper medial portion. We call it the uncinate. That sticks its head into the sublingual space, just sort of right over the mylohyoid muscle. And then we have our sublingual gland, and that lives within the sublingual space, or sometimes people refer to it as the floor of mouth. So the good news for patients is that salivary gland tumors, they're really not that common. They only account for about 3% of all head and neck tumors. And the majority of these, probably upwards of 80%, are going to arise in the parotid gland. And that may simply be because the parotid gland is the biggest and it takes up the most real estate. This is probably the most important thing I'm going to tell you during this talk, or one of the handfuls of most important things. So if you're going to remember one thing from this talk, maybe this is it. And that is that the smaller the salivary gland is, the more likely that a mass arising from it will be malignant. So at baseline, if you're dealing with the parotid gland, any given mass has a relatively low chance of being malignant. That risk increases as you go to the next smaller gland, which is the submandibular gland, and that risk really increases when we deal with the small sublingual glands and the minor salivary glands. So for instance, take all comers. Parotid gland masses, maybe only about 1 in 5, so 20% or so, will be malignant. Not terrible odds. Take a look at the submandibular gland. We're talking a gland that's a coin flip in terms of whether or not a mass is going to be benign or malignant. Now take a look at the sublingual and minor salivary glands. We're talking upwards of 60, maybe 80% of the time, these are malignant tumors. So the smaller the gland is, the higher the risk of a mass being malignant. The other thing that's important to keep in mind is these salivary gland neoplasms are much more common in adults than they are in children, but unfortunately, there's a higher proportion of malignant masses in kids. So if you're a kid with a salivary gland tumor, there's probably a 2 to 3 times increased risk of it being malignant than if it were in an adult. Okay, so this is sort of the overview of what we're going to talk about today. That was the brief introduction. Now we're going to move on to what I have to give you a warning is literally the most painful portion of this lecture. Honestly, I think it's the most painful portion of any lecture that I've put together. But unfortunately, it's an important topic and it warrants at least 5 minutes of attention. And that has to do with staging of salivary gland tumors. You know, there are people out there that just love staging. I have a few people in mind. I won't name who they are. But in general, I think that radiologists don't really enjoy it. But the problem is it's important, right? Because patients need to be appropriately staged by the AJCC 8th edition because that will help dictate treatment pipelines and pathways. So as a radiologist, there are some things you need to know about it. So without further ado, let's get into staging and get it over with. Okay, so all of this staging that I'm going to talk about in this talk is based upon the American Joint Committee on Cancer, or the AJCC 8th edition TNM system. And that TNM system stands for T, which is the size and extent of tumor. So the T is for tumor. N is for nodes, so that has to do with the involvement of regional lymph nodes. And M is metastases, and we're talking about distant metastases. So you break it up into T, N, and M categories, and each of those categories can be given a numerical qualifier, up to 4 numerical qualifiers. They don't all go up that high. But those sort of are used to indicate or triage the severity of each of those categories. Now there's a few other descriptors that you'll see used. The first is X. That just simply means if you see X next to one of the T, the N, the M, that means it cannot be assessed or it's unknown. You may see sort of a caveat of a C next to some of these staging categorizations. That means that it's based upon clinical grounds. That can be changed to a P if it's confirmed histopathologically. Okay, so we're going to move from the sort of overview of what is TNM, and we're going to talk about the things that matter in terms of staging salivary gland tumors. And so we'll start with the T category. And when you start with that, you thumb through the AJCC 8th edition and you find this table. And if you're anything like me, your mind just can't process this. When you look at it, your head just starts spinning, right? It's hard to wrap my head around these things. So what I try to do, what I've tried to convince myself in my mind that I can do is to break these complicated wordy tables up into discrete packets of information that I can remember. And I'm going to highlight a few things that I think will help you to at least sort of create a construct to remember how to approach the T category. And that's to look at a few numbers and to look at some important structures that can be involved. And so if you're going to remember numbers for the T category, it's less than 2, 2 to 4, and greater than 4. Those will define T1, T2, and T3 tumor. And then if you get into the bad stuff, the T4 tumors, just remember some of the things that go into those categories. Involvement of skin, mandible, EAC, and cranial nerve 7, or is it really bad involving the skull base, the pterygoid plates, or encasing the carotid? Okay, so let's simplify this T category. We'll use that to sort of figure out, is it the good, the bad, or the ugly of tumors? So first of all, we look at size. Is it less than 2 centimeters? That's T1. Is the tumor between 2 and 4 centimeters? That's T2. Is it greater than 4 centimeters in size? That's T3. Next, we look at behavior. Is it demonstrating bad behavior? That's T4A. That includes invasion of the skin, the mandible, the external auditory canal, or the facial nerve. Or is it showing ugly behavior? Is it invading the skull base, including the pterygoid plates, or is it encasing the carotid? So instead of looking at that complex chart that has a lot of words on it, just remember, 2, 2 to 4, greater than 4, and then those things that get involved that upstage you to T4 tumor. Then you have to move on to your in categories, the clinical in categories. And again, when I see a chart like this, it makes me want to vomit. Like it just makes me sick at my stomach trying to sort through these charts and memorize things. But hopefully what we can do, and I'll just keep it on this slide to sort of gross you out a little bit further, hopefully what you can do is break it up into little discrete pieces of information that are easier to remember and therefore make it more digestible. Sorry for the bad pun. So how do we make this more digestible? Just a few things to remember. When you're dealing with in category, your numbers change. Less than 3, 3 to 6, greater than 6. You want to look at, do you have more than one node involved? Are the nodes unilateral, bilateral, or contralateral? And do you have nodes that are greater than 6 centimeters? And importantly, extranodal extension. So just a few things. Just a few things that are in yellow here. Those are the things that you need to sort of keep in the back of your mind that'll help you to differentiate all these different in categories. So let's try to simplify the in category. Here's how I do that. First thing to remember, multiplicity matters. So if you have more than one node involved, you're talking about, at a minimum, N2B disease. Keep in mind the laterality. Laterality matters here. If you have bilateral or contralateral nodal disease, you're talking at least N2C category. And then size matters. If you have a node greater than 6 centimeters in size, you're dealing with at least N3A disease. Now, we can have a philosophical discussion about whether lymph nodes can actually get to be 6 centimeters in size or greater. I personally don't believe that they can. I can't prove that to you, but I don't think they can. I think if you're dealing with a lymph node that's that big, you're probably dealing with a conglomerate of multiple nodes that have sort of adhered or matted together. Neither here nor there. If you measure out a lymph node or a nodal conglomerate, and in its greatest diameter, it's an important distinction, AJCC 8th edition says measure the largest diameter regardless of plane. If it's greater than 6 centimeters, you're dealing with at least N3A disease. And then next is look for extranodal extension. Look for the tumor itself that is metastasized to the regional lymph nodes. If it's extending outside of the capsule of those nodes and infiltrating and invading the surrounding structures, that's extranodal extension. Something, admittedly, we're not great, certainly not perfect, but we're probably not even great at calling with high specificity on imaging. That's okay, you have to raise that concern. The biopsy or the neck dissection will give you clarification on whether or not that was true. But if you have extranodal extension, in general, we're talking about N3B disease. There's a small caveat that we'll discuss in a couple slides. So, again, go to the chart. I don't memorize these charts. You can always look them up at your fingertips. But keep in mind the things that matter when it comes to in category for salivary gland tumors. Multiplicity, the laterality, the size, and extranodal extension. Remember those 4 things and put those 4 things to work. That will allow you to report the things that go into staging. All right, then the last category, the M category. Fortunately, this one is binary. I can handle this. M0, you have no metastases, no distant metastases. M1, you do have distant metastases. Super easy. Most common site to have metastases from these salivary gland tumors would be the lungs, so we need to make sure we're looking at the lungs. Okay, I said there were a couple of staging caveats, and you know, these are only thrown out to make life more confusing, I'm convinced, but once you have histopathologic assessment, if you have a small lymph node, in other words, one that's defined as being less than 3 centimeters in size, and if it has extranodal extension, they actually downgrade that to an N2A for the small lymph nodes. So that's one caveat. The second caveat to keep in mind is, if this is lymphoma involving the salivary gland, you stage it as lymphoma and not as a salivary gland tumor. We'll talk about how the parotid glands can have nodal lymphoma. The other major salivary glands can have lymphoma, not the nodal variety. That only occurs in the parotid because they're the only major salivary glands that contain lymph nodes. But if you have lymphoma involving a major salivary gland, you stage it as a lymphoma per AJC 8th edition, not as a salivary gland tumor. And then lastly, the last caveat, if you have minor salivary gland tumors, those get staged as if it were a squamous cell carcinoma originating from that site rather than a salivary gland tumor. Okay, so those caveats aren't too difficult to keep in mind. All right, so then you take the T, the N, the M, and you put it together and you come up with your final stage grouping. And you look at a chart like this, and if you're anything like me, the first thing that happens is your eyes glaze over and they roll back into your head because it's yet another table, and I have a hard time regurgitating these, and that's okay. That's actually not a problem. Just remember the basic key things that go into the staging and look for those, report those features, and then you can look up these tables and use those to report the actual staging if that's something that your clinicians want you to do. So let's look at the stage grouping really quickly. One last thing, one last ugly table before we move on to tumors. And just try to make this into more digestible categorization. So these are the things here in yellow that I think can help you out. So first of all, if it's tumor in situ, you're stage 0. That's easy enough. If it's T1 category tumor, it's stage 1. 1 and 1. If it's T2 category tumor, it's stage 2. The 2's line up. If it's T3 category tumor, that's stage 3. Or if you have N1 nodal disease, that also puts you into stage 3. Now where it gets ugly are the stage 4s, and you have a stage 4A, a 4B, and a 4C. But just take a look at your T4A, that goes with stage 4A. That's pretty easy. Or if you have any T category, T0 up to T4A, but you have N2 nodal category, that will also put you into stage 4A. If you have N3 category, that's going to put you to stage 4B, or if you have T4B tumor, that puts you to stage 4B. So again, the T4A goes to stage 4A, the T4B goes to stage 4B, the N2 goes to stage 4A, the N3 goes to stage 4B, and then honestly making it quite easy, regardless of your T, regardless of your N, if you have distant metastases, that puts you at stage 4C disease. So once you start approaching these, you can kind of use those individual handful of things, those discriminators basically, that can make your job a little bit easier. The bottom line is your role as a radiologist is to look for and to report the things that will upstage or appropriately stage the disease. Okay? I personally do not report staging in my reports. Okay? Some people do. That's great. I have no problem with that. I personally don't. That's because where I work at, we have a very robust tumor board, very collegial tumor board. We work very closely with the ENTs and oncologists and radiation oncologists and come up with the appropriate staging in the tumor board setting, and there's no need for me to give it a stage and potentially pigeonhole people without knowing all of the facts about the patient. And that's how it works for me. I just report the things in my reports that are salient for coming up with the staging. Your individual hospital system may be very different in how it's practiced, and that's fine. If your clinical colleagues would like you to report these as discrete stages, do it. That's fine. It's not just that I'm against doing it, it's that it's sort of redundant, and honestly I think it gets done better in that group setting here, but that's my practice pattern. So when it comes to staging, to sort of wrap this up, I like to keep it simple. I take the K.I.S.S approach, keep it simple, stupid. So I look at the primary tumor. How big is it? Less than 2 centimeters, between 2 to 4 centimeters, or greater than 4 centimeters. What's it invading? Is it invading the skin, the mandible, the EAC, or cranial nerve 7? Or is it doing even worse stuff like invading the skull base, the pterygoid plate, and the carotid? Then you look for those metastatic lymph nodes. You report their laterality. Are they ipsilateral to the tumor? Are they contralateral? Is it bilateral? Report the size. I don't report the size of every lymph node. You look for the index nodes, the ones that matter, the ones that are going to change your staging. Are they all under 3 centimeters? Fine, just say that. Are they, some of them between 3 and 6 centimeters? Are any of these nodal conglomerates greater than 6 centimeters? And then, do you have findings that look like extranodal extension that need to be confirmed histologically. And then lastly, are there distant metastases? So if you can report these things in your report, that's really what you need for the staging purposes. Okay, enough of that. Thank you for surviving that and getting through it with me. Next, we're going to move on to the more exciting stuff, and that's our tour of all of these really interesting salivary gland tumors and kind of their characteristic imaging findings. So we're going to start out with parotid gland neoplasms. And as you can see, there are both benign and malignant tumors that arise from the parotid gland. So we'll start off by talking about the benign tumors. So first up is the pleomorphic adenoma, also goes by the name of a benign mixed tumor. And this is going to be your most common parotid space mass, somewhere on the order of 75–80% of the time. This is what you're dealing with. These are, for the most part, going to be found in the superficial lobe of the parotid. Okay, and that may simply be because, 75–85% of the time, the superficial lobe of the parotid makes up, 75 or 85% of the bulk of the parotid gland, and maybe that's why they're seen there so commonly. You can certainly see them in the deep lobe. They just happen to be much more common in the superficial lobe. These get the name of benign mixed tumor because they contain epithelial, myoepithelial, and stromal components. And despite their name of a so-called benign mixed tumor, these can actually be bad actors for a couple of reasons. First of all is the risk of seeding with biopsy. That's really quite a small risk if you're doing coaxial technique and aspiration. If you're doing an excisional biopsy without complete resection, you can really get the patient into some trouble if you spill tumorlets within the cavity, because it can recur like crazy. That's why we try to avoid doing transoral biopsies of deep lobe of parotid tumors, because of the risk of seeding the oral cavity with recurrent disease. But also, importantly, a small but still significant segment of these, if given time, if not taken out as they run their natural history, they'll eventually break bad and become malignant, so-called carcinoma ex pleomorphic adenoma. So what do they look like? Well, when they're small, they tend to be quite T2 bright. That signal can change a little bit as they get larger, but when they're small, they're T2 bright. You can see they have circumscribed margins. I'm going to mag this up just so you can get a better sense of what these margins look like, because they oftentimes have this very characteristic bossylated appearance to their margins. And by bossylated, I mean this lumpy, bumpy, kind of looks like a happy cumulus cloud type of look. So that gentle sort of microlobular appearance to their borders is very, very consistent with a pleomorphic adenoma. They tend to enhance fairly uniformly, especially when they're small. When they get bigger, that enhancement and that signal becomes more heterogeneous. And when they get very large, particularly if they're coming from the deep lobe, as this one is, they can exert mass effect on the palatine tonsil, the aerodigestive tract, and the pharyngeal-mucosal space. So they can get quite big. And there's honestly very few tumors that live in the deep lobe of the parotid. They get this big without killing you, first of all, but they get this big but yet look so benign, kind of with this pear-shaped configuration. When you see that, that's almost always going to be a pleomorphic adenoma. Next are Warthin tumors. They go by the somewhat unfortunate non-eponymous name of a papillary cystadenoma lymphomatosum, which is quite a mouthful, which is why even people who hate eponyms still usually call these Warthin tumors. These are seen more commonly in older men, and there is an association with smoking. We do see them in women as well, but they are more common in men. This is the second most common parotid mass, and these are interesting because about 20% of the time these will be multifocal. They can be bilateral. Sometimes they can even be extraparotid, which is interesting. But they can be unilateral or bilateral. They can be multifocal within the gland itself. These are a tumor that, not always, but they do have a stronger predilection for involving the parotid tail. Parotid tail is sort of that portion of the parotid that hangs down below the angle of the mandible. So we call tumors that arise in the parotid tail, sometimes they're called parotid earring lesions because they sort of hang off like earrings off of your earlobe. But this is one of those tumors that kind of likes to live there. These have, quite fortunately, a very low malignant potential. Very, very rarely do these have malignant potential. So it's a benign tumor. What do they look like? Well, here's where the challenge comes in. They have a lot of variability in their appearance. They can be solid and circumscribed, as this case nicely shows. That looks like a pretty benign mass. Can't be certain it's benign without biopsying it, but it has features that look benign. About a third of the time, it'll have a cystic component, and that's where it gets complicated, because then you're scratching your head saying, well, is this getting necrotic? Should I be worried that we're dealing with a necrotic tumor that's something that's more aggressive, or is this just a cystic component within a Warthin tumor? The enhancement can be quite heterogeneous and variable. If you do fancy things like DCE and perfusion, you may see rapid enhancement and rapid washout in these. Unfortunately, these, along with many of the other salivary gland tumors, can take up FDG, even though they're benign. So unfortunately, FDG, PET imaging of salivary gland tumors, it has an important role, don't get me wrong, but the specificity really is an area that is challenging and a bit lacking in these. So they can have FDG uptake. That's always causes some consternation. The other thing that causes trouble is the fact that these can be relatively low in signal intensity on the ADC map. I like to preach the value, the importance of doing ADC imaging. I think it's really an important tool. ADC is sort of a rough marker of tumor cellularity, so the darker something is on ADC, the more likely it is to be cellular, therefore the more likely it is to be malignant. Well, unfortunately, these are one of the ones that doesn't read the standard playbook. These can be pretty dark on ADC, yet still a benign tumor. So unfortunately, because of the confusing mixed bag in terms of the imaging appearance, these do require biopsy or excision for definitive diagnosis. Next are schwannomas. These are simply uncommon sites of common masses. We all know what schwannomas look like. Round, maybe fusiform, circumscribed, typically avidly, maybe a little heterogeneously enhancing. They may have intramural cysts. That's the same kind of appearance that you'll see here. Same appearance you see elsewhere in the body, just sort of an uncommon side of it. But this will occur along the branches of the facial nerve as they run through the parotid gland. And because of the close association with the facial nerve and its branches, management of these is a little controversial, because even though they grow eccentric to the nerve of origin as a schwannoma, there is still a risk of facial nerve injury with resection, and that's an important nerve that a lot of people are quite leery of increasing the risk of injury to. So the management is a bit controversial with facial nerve schwannomas within the parotid. Next is a lipoma. Lipomas, much like the schwannomas that we just looked at, this is simply an uncommon site of a common mass. Okay, you all know what lipomas look like. They're fat density. On T1 weighted imaging, they have sort of a circumscribed but lobulated appearance. They're T1 hyperintense. They're also T2 hyperintense. They don't enhance. If you use fat saturation techniques, they're going to get dark and sad out. They can be multiple in rare occasions. Sometimes some syndromes are associated with that. But in general, these look like lipomas elsewhere. We happen to see them fairly uncommonly here. All right, so those were the benign tumors of the parotid, at least the major ones. We're going to focus on malignant parotid tumors. And this is not comprehensive. These are just the big, most common parotid gland malignancies. So the most common parotid malignant tumor is going to be Mucoepidermoid Carcinoma. And these arise from epidermoid and mucus-secreting cells within the ductal epithelium, within the glandular ducts. And unfortunately, it's a bit of a spectrum tumor. So when it's small, when it's lower grade, it may be fairly circumscribed in its appearance. But as it becomes higher grade, as it enlarges, it becomes more infiltrative and indistinct in its margins. This tumor is the one that is known, it's most famous for having nodal metastases. So if you have a mucoepidermoid carcinoma in the parotid, you need to be looking for nodal metastases. Can it cause perineural tumor spread? You betcha. It just happens to occur less commonly with mucoepidermoid than it does with adenoid cystic. But truth be told, any of these malignant salivary gland tumors can have perineural tumor spread. It's not just adenoid cystic. Unfortunately, these are also known for late recurrence. So if you have a patient with Mucoepidermoid Carcinoma, they're sort of buying themselves into a lifetime of surveillance because the risk of having late recurrence is so high. One of the features about mucoepidermoids, and you can apply this to any other major salivary gland tumor, the margins are quite helpful in helping to predict the tumor grade. Doesn't tell you what it is, doesn't tell you what the histology is, doesn't tell you what the final path is, but it gives you an important clue about whether or not you're dealing with something that's benign and or a low-grade malignancy, or whether you're dealing with something that's a high-grade malignancy. Kind of like mammography in the sense, you look at the architectural distortion, you look at the indistinct, irregular infiltrative margins. Apply those same kind of concepts to the salivary glands. Mucoeps can have these low-density mucocystic areas. You can see the arrows pointing at one right now. Therefore, they've got areas internally that tend to be T2 bright, but pay attention to the areas that are T2 dark. I honestly think that's more important than the T2 bright stuff. Okay, they used to say, oh, if you see T2 bright in a salivary gland tumor, it's probably benign. False. You can have malignant tumors that are T2 bright within the salivary glands. What I turn my attention to on the T2 weighted imaging is less the T2 bright stuff. Yeah, it's helpful to see kind of where the tumor's going, but see if it has intrinsic T2 dark material within it, because that, along with your low ADC signal intensity, is suggestive of cellular areas within it. The more cellular it is, the more likely it is to be malignant. If I'm going to do a biopsy on one of these, I try to target the T2 dark areas. So look for that characteristic. It's not pathognomonic for mucoep, but it's something to look for. That gives you some insight into the fact that you're dealing with something that's more aggressive. And the same tumor, look how heterogeneous this enhancement is. I mean, I can't even trace the margins of the tumor on this post-contrast sequence. So they can be quite heterogeneous in their enhancement. And again, just sort of extolling the virtue of using ADC map. It's not perfect. You should never do it just based upon ADC alone, but it's another data point that helps to tell you about the cellularity of your tumor. These tend to have lower ADC than benign mixed tumors. Next is our adenoid cystic carcinoma. This is going to be the second most common parotid malignancy. These arise from the peripheral ductal epithelium, and these also have sort of a spectrum appearance. Early on, lower grade, may be quite circumscribed. That will become more infiltrative and indistinct as the tumor gets bigger and as the grade gets higher and higher. This is the one that classically is associated with perineural tumor spread. As you can see on this diagram here, we have this sort of nodular studded appearance along the facial nerve branches within the parotid, but don't forget about the auriculotemporal nerve. That's the extracranial bridge that links the facial nerve over to the cranial nerve V3 in the infrazygomatic masticator space. So this is that auriculotemporal nerve right here with perineural tumor spread along it. Critical nerve, don't forget about it for whenever you're assessing these cancer patients. We'll talk just a little bit more about that at the very last portion of this talk. Just like mucoeps, these unfortunately have a propensity to have late recurrence, so long-term surveillance is really critical in these patients. So, I said this before with mucoep, I'll say it again for adenoid cystic, I'll probably say it again before this talk is over. Look at the margins. Those margins can help you to predict what the tumor grade is going to be. Are we dealing with something that looks lower grade, maybe even something that looks benign, or are we dealing with something that looks high grade, infiltrative, ugly? As this image shows nicely, these are kind of low to intermediate signal intensity on T1 weighted imaging, and they have typically fairly moderate T2 signal intensity. As you can see here, it's just a little bit brighter than the parotid gland itself. However, as the grade increases, as it becomes a more cellular tumor, that T2 signal intensity can certainly decrease, just like the ADC. These do tend to have pretty avid enhancement. These are oftentimes described as having a flame-like appearance. Again, indistinct margins, though. It's hard to trace out exactly where the margins are with this tumor. And speaking of enhancement, you have to follow the nerve. So here we can see in the pes anserinus that bifurcation of the facial nerve in the parotid region. We can see all this enhancement, but look deep to that. We've got enhancement tracking along This is sort of trekking along the auriculotemporal nerve and probably also the pterygoid musculature back to the cranial nerve V3 in the infrazygomatic masticator space all the way up to the foraminal valley. So don't forget that auriculotemporal nerve and that important perineural tumor spread route between the extracranial cranial nerve 7 and cranial nerve V3. And again, ADC map. It's imperfect, but it's a nice data point to look at. The lower the ADC, the more likely it is a cellular tumor. If it's a cellular tumor, it's more likely to be malignant than benign. Not a perfect cut point, but it's just another layer of icing on the cake of trying to come up with the diagnosis. Next is the malignant mixed tumor, and this comes in two flavors. You can have carcinoma x pleomorphic adenoma, again those BMTs that broke bad, or you can very rarely have a carcinosarcoma, almost case reportable with those. Early on, these will oftentimes mimic benign mixed tumors because, truth be told, most of these probably started as benign mixed tumors at some point in their life. These may have areas that have decreased T2 signal intensity within them, and that's a helpful tip-off that maybe you're breaking bad and becoming something more aggressive like a malignant mixed tumor. They also tend to have lower ADC, and late in disease they become aggressive in their appearance and very invasive and infiltrative. Take a look at this one right here. I can't even make out the distinction between where it's involving the parotid and where it's invading the masseter. The whole area has been replaced by tumor in this patient that had a malignant mixed tumor of the left parotid. Just a few words about lymphoma. You can have three main variants of non-Hodgkin lymphoma that involve the parotid gland. You can have primary nodal non-Hodgkin lymphoma. Again, parotid gland, only major salivary gland that contains lymph nodes. They sort of get wrapped into it during its embryological development. So you can have lymphoma that involves only the nodes within the parotid. You can have systemic non-Hodgkin lymphoma, which is what we're looking at in this image here. And you can even have a primary parenchymal non-Hodgkin lymphoma. So the three flavors, again, primary nodal, systemic nodal, or primary parenchymal. With the nodal non-Hodgkin lymphoma, what you're looking for is multiple, oftentimes multiple anyway, defined intraparotid masses. And oftentimes, not always, but oftentimes it will be bilateral. Something that can help you out is to look for associated findings. In this case, cervical adenopathy in this patient with CLL. You can see they've got these solid, mildly enlarged, kind of rounded cervical lymph nodes, in addition to the bilateral intraparotid lymph nodes that are enlarged and have that same similar rounded, solid morphology. The trouble comes with these parenchymal non-Hodgkin lymphomas because they look like infiltrative masses. I mean, I couldn't look at this and say, oh, yeah, that's definitely a parenchymal variant of non-Hodgkin lymphoma. No, I mean, this could very well have been adenoid, cystic, or mucoep. You just can't tell without doing a biopsy. Also, critically important thing to keep in mind is metastatic disease to the parotids. So the intraparotid and periparotid lymph nodes are the first order nodal drainage of the ear and the external auditory canal. So here we can see this necrotic rounded mass within the right parotid. Look carefully. We have this huge fungating invasive mass within the right external auditory canal and external ear. But they're also the first order nodal drainage of the scalp and the face. So you need to be thinking about the possibility that an intraparotid mass is a metastatic deposit, a metastatic nodal deposit from things like squamous cell carcinoma and melanoma of the face, the ear, or the scalp. You can get systemic mets here. I mean, if you work at a big cancer center like I do, you'll see this from time to time, but it's rare. You know, I've seen lung, I've seen breast, GI, colon, prostate, renal, you name it. You can get nodal mets into your parotid lymph nodes, but usually those are patients that have profoundly disseminated systemic disease. And so the cat is typically way outside of the bag. It's not like that's the first node that shows up with those. One thing that can be helpful is that metastatic disease may be multiple. Not always, but it may be multiple. So this is one of those things, along with lymphoma, Warthin tumors, maybe oncocytomas, that I throw into my differential diagnoses whenever I'm dealing with multiple or multiple bilateral parotid masses. So we talked about the main players, but there are others. Okay, do you guys remember Lost when they met the others? So there are others when it comes to parotid tumors, and we're just going to blow through these because frankly, their imaging appearance is all very nonspecific. They all kind of look the same. So, as I take another drink of coffee, we're looking at an axial CT image. We have this infiltrating, indistinct, maybe partially cystic or necrotic mass in the right superficial parotid, trying to climb its way into the deep lobe of the parotid. This was a squamous cell carcinoma. I can't tell the difference between that and this image on the right, which was a salivary ductal carcinoma. Has a quite similar appearance. This one, infiltrating mass, a little bit more solid. This was a myoepithelial carcinoma. Here's an infiltrating, almost necrotic looking mass in the left parotid in a different patient on MRI. This was an acinic cell carcinoma. Kind of a solid but irregular shaped infiltrating mass spanning the superficial and deep lobes. You can see on this PET MRI that it's markedly FDG avid. This was a poorly differentiated salivary ductal carcinoma. One that looked a bit similar to that, but more in the deep lobe. Infiltrating, large, ugly mass, has some intrinsic dark T2 areas that are concerning. On PET MRI, you can see that there's FDG uptake. This was an epithelial myoepithelial carcinoma of intercalated duct origin. Totally would have led with that. I mean, I wouldn't have given a differential, right? No, I mean, you look at these, you can't tell what it is. Let's be honest, you can't tell what this is looking at the imaging. That's okay. Size, what's it involving? What's it doing to the facial nerve? Is there perineural tumor spread? Are there nodal metastases? Report the things that you can report. Your job as the radiologist isn't to give the final histopathologic diagnosis. If they want to know what that is, it's going to need a biopsy. And that's something that you can do. Here's another interesting one. Sort of a bit of an infiltrating, avidly enhancing, almost flame-shaped mass. Adenoid cystic, right? Well, in this case, take a closer look. A little bit speckly with areas of intrinsic T1 bright signal. It's got some high-velocity flow voids within it. This was a paraganglioma. Yes, I biopsied it. Yes, it bled a bit. But, you know, the imaging appearance of these atypical tumors, it overlaps so much with the appearance of all the other tumors that we really cannot tell the histopathology based upon the imaging. That's not your role as the radiologist. So here's how I go about reporting these parotid masses. The critical thing to keep in mind up front, I just said it, I'll say it again, imaging has poor specificity for predicting the final histopathology. That's okay. That's not your job as the radiologist to come up with. That's the pathologist's job. I advocate using sort of a checklist manifesto approach to these. So here's my checklist when dealing with reporting parotid masses. Where's it located? Is this isolated to the superficial lobe? Is it isolated to the deep lobe? Does it span both? What's its proximity to the expected course of the intraparotid facial nerve? Where, in other words, where does it live with respect to that retromandibular vein, which is our surrogate marker for the facial nerve? What's the size? We talked about how that matters for your T category. Look at those margins and look closely at those margins. Are they painting a picture of this being something benign or perhaps a low-grade malignancy? Or are they painting a picture of this being aggressive and high grade? What about multiplicity? If it's multiple, I'm thinking Warthin, metastases, lymphoma, maybe oncocytomas. Is there perineural tumor spread? What's it doing to the facial nerve? Is there involvement of the auriculotemporal nerve? And then look for nodal metastases. That's my checklist. I go through that list every single time. And once I've done that, and I say, yeah, there's a mass, I think that it's most likely to be aggressive malignant, then I put this in my report. And I sort of borrowed this, stole this, however you want to look at it, from someone who I really admire, which is Pat Hudgens or Pat Reiner. And this is sort of the method that she preaches using, and I think it's a very practical and pragmatic approach. Report the things that matter, talk about the things that you can talk about with certainty. But at that point, I put in my reports, further imaging will confer no additional specificity to the diagnosis, and then recommend a biopsy. If you want to know what it is, you're going to have to put a needle into it. And as a radiologist, that's something that you can do, whether it's through ultrasound or CT. This is in your wheelhouse. This is something that you can do to provide a clinical service to your ENT and oncology colleagues. Okay, we're going to move on to our submandibular gland neoplasms next. And these again can be broken up into benign and malignant tumors. And so we'll talk about the benign, and you'll notice the list gets shorter for each of these. So the pleomorphic adenoma makes its return. This is, again, the benign mixed tumor. This is going to be still your most common submandibular gland tumor, so that's a good thing. These tend to be slow-growing and painless. Again, they get their name as benign mixed tumor because they contain epithelial, myoepithelial, and stromal components. But just like in the parotid, these can be bad actors. We talked about that risk of seeding. That holds true here as well. Something that you can mitigate by being careful with your biopsies. And also keep in mind that risk of some of these, if they don't come out, if they live their life expectancy as a tumor, some of these will break bad and become carcinoma ex pleomorphic adenoma. So what do they look like? Well, they tend to have defined margins, at least when they're small on CT, and you can see fairly defined margins. We'd see those margins better on MRI, but kind of getting a circumscribed look here on the CT. They tend to have a bit of heterogeneity in their density or attenuation, oftentimes still a little bit low density. They may or may not have calcifications. Feel free to report it if they do. I don't find that to be a particularly useful discriminator. They will typically have mild to moderate enhancement. This one that I'm showing you is sort of a poorly enhancing one. That happens. And on MRI, what do they look like? Well, they tend to be low or lowish on T1 signal intensity and bright on T2 signal. So you can see just how bright this is. Now, there are a couple features about this one in particular that I want to point out that are a little suspicious. Yes, it largely has circumscribed margins until you get to, about the 3 to 6 o'clock position over here. Gets a bit indistinct. That would be worrisome. And again, there are some areas that are darker in T2. So this one doesn't quite make me feel great, but this ended up still being a pleomorphic adenoma. In terms of enhancement, they tend to enhance a bit avidly, but it's also typically fairly heterogeneous in its enhancement as well, particularly as they get larger. As you can see here, very heterogeneous enhancement of this tumor. We can get lipomas involving the submandibular gland. Again, just an uncommon site of a common mass. You know what they look like. They're circumscribed, they're mildly lobulated, they're fat density, they're T1 and T2 bright. They sat out with fat saturation and get dark. They don't enhance. Rarely are they multiple. So you know what lipomas are. All right, let's move on to our malignant submandibular gland neoplasms. Right from the starting blocks, I need to make the important statement, reiterate something I said at the beginning of the talk. When you're dealing with a submandibular gland, you're talking about something that has about a 50-50 chance of being malignant at baseline. Okay, it's a coin flip as to whether or not you're dealing with cancer. Keep that in mind. Submandibular carcinomas are the most common cancer that we're going to see here. The most common variant of that will be the adenoid cystic carcinoma, followed by mucoepidermoid adenocarcinoma. This one here I'm showing you is an adenoid cystic. Note how that looks quite similar to that benign mixed tumor that I showed you a slide prior. You can also get squames here. You can have undifferentiated carcinomas, and don't forget that carcinoma ex pleomorphic adenoma. So, submandibular gland carcinomas, what do they look like? Well, when they're low grade, they tend to be a bit more circumscribed. I mean, this is a very circumscribed mass that we're looking at here. They tend to be T2 bright, even a bit ADC bright when they're low grade. So ADC is not perfect. Enhancement tends to be variable. Here's one that's got some heterogeneous enhancement on CT. But as you transition to being a high-grade tumor, they become more infiltrating and invasive, maybe necrotic in appearance. They will have portions that are lower in T2 signal and lower in ADC signal due to cellularity. And one thing I want to stress to you again is it's impossible to give a specific histologic diagnosis based upon the imaging. It's impossible, and I would suggest you don't even bother trying, because you're going to be wrong more often than you're right. Not just you, me. I don't care who the head and neck radiologist is, how good they are at their job. If they're offering great predictive value on what the final histopathology is, perhaps take it with a grain of salt, because there is so much variability in appearance of these and so much overlap. That's okay. Keep in mind what your job is. Your job is not to give the histopathology. Your job is to talk about what it's doing, where it's going, what it's getting into, perineural tumor spread, nodal mets, that kind of stuff. So this one was a squamous cell carcinoma. Here's another ugly one. Infiltrating, invasive, kind of necrotic looking in portions. This was a sclerosing epithelial myoepithelial carcinoma. I would have never put that in my report as a differential consideration. Instead, it's probably more important just to say whether or not you think that this is a high-grade malignancy or something that's more in the low-grade or benign camp. But regardless, tissue is the issue. They need a biopsy. Can you get lymphoma involving the submandibular gland? Yes. It's much less common than primary parotid lymphoma. This can be a localized mass within the submandibular gland itself, or it can present with just diffuse glandular enlargement. These oftentimes have a bit of a lobulated appearance, as you can see in this contrast-enhanced CT. You may or may not see cysts. You may or may not see calcifications. I don't find those to be particularly helpful discriminators. Feel free to describe them all you want, but I don't think it gives you any more specificity. One thing that can be helpful with lymphoma is to look for adenopathy, so be on the lookout, obviously, for cervical adenopathy with these. And here's my checklist. I, again, take that checklist approach when reporting these submandibular gland masses, just like I do with the parotid masses. What's the size? What do the margins tell you? Are we looking something that appears to be more on the benign or low grade end of the spectrum, or are we talking about something that looks more high grade? What's it invading? Is it getting into the mandible that sits right next to it? Is it going crazy and getting up to the skull base, the pterygoids? What's it doing to the carotid space? Is it extending out to the skin surface? Be on the lookout for perineural tumor spread. Adenoid cystic, again, is our main culprit, but any of the malignant tumors can do it. Be on the lookout for nodal metastases. Mucoep is our classic culprit, but again, any of them can do it. Once I've gone through this checklist, I put in my report. Further imaging will confer no additional specificity to the diagnosis. If you want to know what it is, you need to put a needle into it and get tissue. And again, this is something that you as a radiologist can do. These don't have to be referred out to ENT to put a needle into it. Ultrasound is a great tool in the submandibular gland region because it's so superficial. Sometimes if you got to get way up under the mandible, you can think about doing CT as well. But this is something that you can do as a radiologist. Next, we'll talk briefly about sublingual gland neoplasms. Again, these lists just get shorter, so don't worry. We got a few slides to get through still, but we're getting close. Really, the main player in the benign camp is the pleomorphic adenoma. So, fortunately, this is still going to be the most common sublingual gland tumor. This is a nice case that Troy Hutchins lent me. And these can originate from the sublingual gland itself, or you can also get pleomorphic adenomas in the sublingual space that arise from minor salivary gland rests that occur in the sublingual space. We'll talk about minor salivary gland tumors here in about 2 minutes. And these look like benign mixed tumors elsewhere. Keep in mind that risk of seeding, so you have to be careful with your technique when you're doing these biopsies, and the surgeons have to be careful of their fields whenever they're doing excisions. And keep in mind that risk of breaking bad and becoming carcinoma x pleomorphic adenoma. All right, we're going to talk a little bit about the malignant sublingual gland neoplasms. And right out of the starting blocks, I have to drive home this point yet again because it's so critical. You're talking about a tumor that has an extraordinarily high risk of malignancy at baseline. Maybe 60 to 80% of sublingual gland masses will be malignant. Regardless of how they look on their imaging, 60 to 80% of them, just right off the top, we're talking about high malignant risk. So always keep that in mind. Take these very, very seriously. Fortunately, they're quite rare. Of these sublingual gland carcinomas, we see adenoid cystics, mucoeps, and carcinoma x pleomorphic adenomas most commonly, just like within the submandibular. These tend to have variable signal and enhancement. So that last one was quite T2 bright. Here's what it looks like when you give contrast. Kind of poorly enhancing, almost cystic in appearance. It does have some peripheral enhancement. That peripheral enhancement, if you look carefully, doesn't enhance as much as the rest of the sublingual glands. So see how this area in here, it enhances, but not as avidly as the downstream glands, so that's worrisome. Use T2, use ADC map. The lower the signal on those, we're thinking about bad malignant things because of cellularity. So here's my checklist for reporting sublingual gland masses. It looks like my other checklist. What's the size? What do the margins tell me? What's it invading? Again, these take into consideration some other things like the tongue, the root of tongue, the lingual artery that are close in proximity. Is there perineural tumor spread? Again, not only adenoid cystic, but that just happens to be the classic one. Are there nodal metastases? Think about mucoep, but certainly any of the other ones can cause it as well. Once I've burned through that checklist of things to report, further imaging will confer no additional specificity to the diagnosis. In this case, no matter what you think it is, it's probably going to be malignant. I think these are all patients that need to get referred to ENT quickly, and it may be in the best interest of the patient for them just to do a formal resection rather than you do an ultrasound, guided biopsies, or anything like that, because the baseline risk of malignancy is so great in these patients. All right, we're going to talk a little bit about minor salivary gland neoplasms. So throughout the head and neck, there are scores of tiny mucus and seromucous tubuloalveolar glands within the submucosal surfaces of the head and neck. We may be talking hundreds, even over 1,000. And they're in really all over the place, as you can see here. The lips, the cheeks, the palate, the base of tongue, the retromolar trigone, the peritonsillar region, sinonasal, nasopharynx. Sometimes even see them in the parapharyngeal space, little tiny ectopic rests of minor salivary glands. So they can be virtually anywhere is the take-home point. And virtually any of the previously described pathologies, adenoid cystic, adenocarcinoma, mucoeps, you name it, anything we've talked about previously can occur from one of these tiny little rests anywhere in the head and neck. But fortunately, they're quite uncommon. So just like everything else I've said, our imaging doesn't have great specificity for the final histopathology. That's okay. Talk about what it looks like, what the margins look like, where it's going, what it's invading, and look for features that upstage disease. So here's that same carcinosarcoma patient. This time, we look at the bone window on the CT. We can see it's invading the clivus and skull base. T4 tumor. Also be on the lookout for perineural tumor spread. You can certainly get it with minor salivary gland tumors as well. And that is sort of my segue to talk about the very last thing, which is perineural tumor spread. And this is just going to be a brief rundown. This could be a talk in and of itself. Maybe I should put one together. But with perineural tumor spread, keep in mind your main players within the head and neck. First main player nerve is going to be your trigeminal nerve or cranial nerve 5. So with regard to salivary gland tumors, the most commonly involved main branches will be cranial nerves V2 and V3. You can have perineural tumor spread along the course of the facial nerve as well. As you can see in this diagram, this descending mastoid segment, the intraparotid segment of the facial nerve are involved. But don't forget about the auriculotemporal nerve. I told you we would revisit it. Here we are revisiting it. So the auriculotemporal nerve is the extracranial bridge that links cranial nerve 5 and cranial nerve 7. You have an intracranial bridge as well. That's your greater superficial petrosal nerve. We're not going to talk about that as part of this talk, but there is an extracranial bridge that links cranial nerve 7 and cranial nerve 5, and that is your auriculotemporal nerve. And hopefully with this case I'm going to show you, just sort of burn this appearance into your mind, and it makes it a lot easier to remember how these should look, okay? This patient had adenoid cystic carcinoma of the parotid. They'd had a parotidectomy. They've got recurrence, okay? We see this soft tissue avidly enhancing within the parotidectomy bed. Uh-oh, this isn't normal. Do you see this cord-like enhancement extending from sort of behind the mandible, wrapping its way over, working sort of anteromedial into the infrazygomatic masticator space? That's where my arrow is at, the infrazygomatic masticator space here. But you can see this cord-like enhancement connecting over. That's the course of the auriculotemporal nerve. If we look at the other side, yeah, we've got some enhancement. That's pterygoid venous plexus. This cord-like enhancement is perineural tumor spread. And it hops over to the infrazygomatic masticator space, over to where cranial nerve V3 runs. Let's go a slice up from that. Here's cranial nerve V3. Look how big and thickened and avidly enhancing that is. So we have perineural tumor spread on that. Look carefully at the rest of the image. What else do we have? stylomastoid foramen proximal, the very distal descending mastoid segment, asymmetrically and avidly enhancing and enlarged. We have perineural tumor spread crawling its way into the temporal bone via the facial nerve canal. Let's go a slice down. We're now at sort of the lingula of the mandible, where the mandibular nerve is going to enter into it, and we can see asymmetric enhancement. It's enlarged. We're starting to lose the cortex around it. See how we've, along the anterior margin where that's enhancing, we've lost our dark cortex. It looks a little shaggy through here compared to the other side where it's smaller, and we can see that that dark T1 dark rim all the way around the foramen. So that's been infiltrated with perineural tumor spread. Let's go a slice or two down further south. This whole marrow space of the left mandible has been replaced where it's extended along the mandibular nerve canal. So, in summary, I've provided an overview of parotid, submandibular, sublingual, and minor salivary gland neoplasms. One of the important things that you need to always be looking for would be things that upstage disease, because that's going to more appropriately triage the care of the patient if you put them into the appropriate staging category. I want to stress that it's critical to always be looking for perineural tumor spread. That's something that's challenging. I'm not going to lie to you. It's something that's challenging. Some people even say it's probably standard of care to miss perineural tumor spread out in practice, but I think we can change that. Make sure you're looking for it. I want to drive home this critical point. I've said it multiple times in this talk. I'll say it one more time. The smaller the salivary gland is, the more likely that a mass is going to be malignant. And remember your role as the radiologist. Your role is to image for staging and surgical planning, and you biopsy to get the actual answer. So as always, thanks for joining in. Again, I hope you're staying safe and healthy, whether you're at work or at home during this trying time. I'd encourage you to follow along on Twitter, where I do a case of the day or case of the week from IU Radiology. You can follow along at N.A. Kuntz. You've got my email address if you want to reach out with any questions. But again, take care of yourself, take care of each other. Times are going to get tougher, but we'll get through this, and just stay positive. And take the opportunity. If you get furloughed, if you're stuck at home, great time to dig in, read a textbook, do the things that maybe we should all have been doing more in residency and training, and use it as an opportunity while you're sequestered to really augment and bolster your education. So thanks again. We'll try to get another one of these up here in the coming days. Take care.